Good morning, everyone. Thank you for the trainees joined in our YouTube channel for Urology Viva exam preparation. Today, we are heading towards episode 18 and we are discussing UroTechnology second episode. As you all know, in the first episode, we discussed the instruments for ureteroscopy and stone retrieval. Today we are going to discuss the instruments and technology behind PCNL. We've got a trainee who has volunteered. Welcome.
Good morning, Mr. D, and thanks for this opportunity. I'm happy for this discussion to be recorded and shared through the YouTube and social media for the purpose of training. Thank you so much.
Thank you very much. That's very kind of you. The scenario is you have a 45-year-old female presents with history of left-sided loin pain and recurrent UTI. She was evaluated by one of your trainees and she was found to have left-sided staghorn stone. How are you going to further evaluate her for PCNL surgery?
I'll make sure that she has got all the information for the PCNL procedure based on the Bow's information leaflet. I'll make sure that she knows the risks and benefit of the procedure and also the alternatives. I'll arrange for a CTKUB to better delineate the stone and the anatomy of the kidney, and also for the presence of the other kidney and the morphology of the other kidney. I'll make sure that she has no contraindications for PCNL, like no bleeding disorders. I'll review the CT scan and make sure that there is no anatomical contraindications for PCNL, like a retrorenal colon. On the day of, before the surgery, I'll make sure that she has got a urine study, urine culture, which is sterile. And this is how, and I also discuss in the stone MDT to confirm that this is the ideal approach. And I'll also make sure that if it's like a big staghorn calculus, she is aware that it might need multiple staged procedures, including the endoscopic combined intrarenal surgery. So this will be my initial planning for counseling her for the PCNL.
Okay, you can also use the Bow's information leaflet because we have a very good Bow's information leaflet for PCNL. For the trainees practicing outside the United Kingdom, BOW stands for British Association of Urological Surgeons. We have quite detailed patient information leaflets in simple plain English for most of the procedures. Okay, so how are you going to prepare her? What investigations you plan to do?
So the basic blood test, the FBC, to make sure that her hemoglobin is acceptable level, and also the coagulation parameters to make sure that she has no bleeding diathesis. I'll also make sure that she is not on any anticoagulants. Other urine culture and sensitivity, and CT KUB. So this will be the basic investigations that I do to make sure that there is no contraindication to go ahead with the PCNL.
What are the absolute contraindications for PCNL?
Absolute contraindications are coagulation disorders, pregnancy. If anatomically the colon is retrorenal, and also sometimes on the right side, the lobe of the liver can come really down and it might be difficult to puncture. And also, if the patient's performance status is not acceptable, then that can also be a contraindication. These are the, and also difficulty in positioning the patient because of any hip or any joint problems.
Okay, like untreated infection and is maybe a contraindication. Sepsis is definitely a contraindication. If the patient is septic due to a staghorn stone, what will be your approach?
I'll initially treat the sepsis, and we'll make sure that she has recovered well from the sepsis. And if needed, if there is any obstruction, then a nephrostomy will also be in place. And we'll make sure, once the PCNL is decided, I'll make sure that her urine culture is sterile before the procedure. And during the procedure, I'll make sure that I'm giving the antibiotics which are culture sensitive. And if any doubt, I'll have a discussion with the microbiology team as well to give her the appropriate antibiotics. And if with a history of previous sepsis, I'll give one more dose of antibiotics before 24 hours. So that will be my approach to prevent any more sepsis during the procedure.
Okay, as usual in these YouTube class scenario sessions, we will try to dive deep into the discussion, which may be slightly more than what is required for trainees appearing for FRCS, but more the merrier, and better to know more than what is actually required on the exam, so that you'll be more confident and you can bring in a lot of your own stuffs which will really impress the examiner. Now, if there is a liver on the right side or spleen on the left side is little bit larger or in a position obstructing your access, or as you said, a presence of a retrorenal colon, they are not absolute contraindications. They may be relative contraindications and that may cause the surgery a bit challenging. Let us take, for example, you have a patient with retrorenal colon. How it will change your approach?
Um, I can use the help of an ultrasound guided approach, which can avoid the puncture of the colon. But I'm not sure whether a different changing into supine PCNL will make any difference.
Okay,
I'm sorry.
First thing what you can think is about the various main two approaches like prone or supine PCNL, whether the colon may move with that. But very rarely you may come across a situation where even in supine, you're not puncturing an anterior calyx, you'll be puncturing only the posterior row of calyx, and the retrorenal colon is unavoidable. As you said, ultrasound is very good. It's usually very nice tool to get the bowel visualized, while with C-arm, we can't have any access over the bowel. The two main techniques are using a normal saline to flush the bowel away from your area of interest. So you can decide your track and then do not penetrate beyond the colon and use the normal saline injection technique to create a kind of a space in the perirenal area so that the bowel is getting compressed and pushed away. This technique is quite commonly used when the intervention radiologists are performing a renal biopsy. If a colon or any organ comes in the way, they try to push it away by using the normal saline. Not always successful. Sometimes the amount of normal saline required may be quite high, which is almost equivalent to like extravasation. This can compromise patient's outcome, and presence of too much of normal saline in perirenal area also compromise your stone clearance even when you get an access. The other way, always don't forget laparoscopic guided PCNL. So in laparoscopic guided PCNL, you can mobilize the colon, you can even tuck the colon at the opposite quadrant, and you can very safely do a percutaneous puncture, and under vision you can enter the desired calyx. Once the desired calyx is entered, you can deflate the abdomen. You don't have to keep the abdomen insufflated throughout the PCNL, and do a PCNL as normal. And then the lap port, even a one single camera port will come quite handy. Of course, you can have one more port if you want an extra pair of hand. This is also very useful whenever you're doing some complex PCNL scenarios, like for example, pelvic kidney, unascended kidney, malnutrited kidney, or even transplants. Okay?
Thank you.
Good. Now, this is the image of the patient. Go through the image, please.
So this is a plain X-ray KUB. I can see a radio picture the left renal area, it appears like a complete staghorn. I'm saying that because I can see the full calyceal impressions and part of the staghorn in the pelvis as well. I can't see any radiopaque shadow on the right renal area, and the appearance of the bones are normal in this X-ray KUB. So I will put like this is a complete staghorn on the in the left kidney.
Okay, so this quite corresponding to her side of the pain, and it's a complete staghorn stone. And how will you explain or go through the staghorn stone, and how can you expect it will be a complex PCNL or a straightforward PCNL?
So the approach to staghorn calculus is one the shape of the calculus and seeing how many calyces it is involving. I will get a more detailed anatomical details with the CT KUB so that I can see if there is any renal abnormal morphologies there. In this case, I'll also be keen to do a DMSA scan to make sure that the function of the kidney is normal on that side. And by these things, I can plan for the PCNL. This appears it could be a complicated PCNL because I can see the calyces are, especially the mid-pole calyce is seeing separate. So it might need multiple punctures, might be difficult to get into the small calyces with a single puncture. So if it is a difficult anatomy, like in a bifid pelvis, or if the calyces are very small, the entry to the calyces are very small, or even in a calyceal diverticulum, I would consider that as complicated, challenging PCNLs.
Okay. As usual, this radiology picture is taken from the website Radiopedia, and our many thanks to Dr. Natalie Yang for contributing these X-rays. For the trainees who are interested, Radiopedia website has got copyright proven many slides and radiology images which can be used for both exam preparations and your own presentations. Few other things what I will add is, as you know, this lady is a middle-aged female, so you can see the outline of the right kidney, so that you can mention without any radiopaque shadows, and you can see a kind of shadow on both sides. Can you explain what this means?
Yeah, so it could, I would expect a high BMI for her. It seems that it is the fold of the skin.
Yes, so this is a perfectly done X-ray KUB, and you can't see the patient's lateral end, so she is almost filling the plate. So these things should be in your mind when you're planning the procedure. As you know, patients with high BMI are quite challenging. What challenges you may face when you're doing high BMI patient for PCNL?
So it could be the procedure-specific challenges and the anesthetic complications as well. For a high BMI patient, the initial positioning is difficult. So most probably we'll have to think about the supine PCNL. The puncture of the kidney is also difficult for obese patients. Other thing, we might have to use the longer access sheets and longer puncture needles, which can be difficult to procure, and the chance of the anesthetic complications are also more in the sense of DVT, PE, and even the recovery from anesthesia can be complicated by chest problems like pneumonia, post-operative delayed recovery. So altogether, a high BMI is considered as a risk factor for PCNL. Yeah.
Okay. So cardiopulmonary reasons are the most predominant. As you said, when coming to the equipments, we need extra long equipments. And you said about the access needle and the access sheath. And also you can say about the telescope, which should be a bit longer. The other thing which you need to concentrate in the X-rays, even though you are doing DMSA scan, you can see in this picture, you can see my arrow, isn't it?
Yeah, I can see.
Yeah, you can see in this picture the renal outline is nicely maintained. So it's a
Yeah.
nice volume kidney with good cortical thickness. Yes, the
Mhm.
stone is completely filling the whole pelvic calyceal system, but
Mhm.
it is not a very spidery dividing calyceal system. The calyx seems to be a little bit simple. So sometimes
Mhm.
these stones will be relatively straightforward when compared to further difficult stones. And
Mhm.
other important thing which you need to go through is the relation to the ribs. Possibly with these available two images, we should assume
Mhm.
this as the 12th rib, but there is
Mhm.
always a possibility that 12th rib may be quite small and this could be
Mhm.
even the 11th rib. Either
Mhm.
way, the best approach for these kind of Sargon stone is a supracostal approach.
Mhm.
So you should be able to do upper calyceal puncture, which gives relatively a better puncture and better access that may
Mhm.
help you to clear most of the upper pole stones, maybe even this calyx and the pelvic stone up to PUJ. You may be easily able to reach the lower pole calyx and sometimes the other stone.
Mhm.
How can you, for example, you are clearing all these stones and you have got a
Mhm.
kind of a small residue here, here, and here. You have cleared
Mhm.
all the other stones. So, what
Mhm.
is your next step if you want a full clearance in one sitting?
So there are three options for that. I can do multiple punctures directly into the small calyces, or two, I can combine it with a flexible ureteroscopy known as ECIRS, endoscopic combined intrarenal surgery, or I can do a sandwich therapy where I can do a ESWL after the PCNL. So this will be my approaches for difficult access stones.
Good. Once we are doing the PCNL, it's always nice to complete it with PCNL itself. And yes,
Mhm.
for some situations, the ESWL sandwich is acceptable. So they do like first ESWL, then do a PCNL to clear it, and then do one more ESWL for the residual stones. The one other technique is instead of puncturing multiple times and dilating, you can just do the needle puncture, and under vision you can try to dislodge the stone. So two
Okay.
punctures to dislodge the stone, but only one puncture with dilatation. You mentioned about endoscopic combined internal surgery from below. That's a good choice. But there is another method available in our armamentarium, which is flexible nephroscope. So you can use a nephroscope from the top, which can be used for clearing the other non-reachable calyces also. So without using the endoscopic combined ureteroscopic approach, for which you need another expert hands, maybe your registrar or somebody should be able to give a hand. Flexible nephroscope also will be quite handy. Okay,
Okay.
good. How will you approach this patient in regards to prone or supine? What are the pros and cons? What is your choice for this patient?
So, in the trust hospital I am working, we do supine PCNLs frequently. So, I shall explain in terms of supine PCNL at first. So, I will meet and greet the patient in the preoperative ward on the day of surgery, make sure that everything is in place, confirm the consent, and address any concerns. I'll mark the site of the procedure, and will make sure that her urine culture is sterile and her other blood tests, especially the hemoglobin level and creatinine levels, are within acceptable range. And during the team huddle, I'll make sure that all the equipments are available. The fluoroscopy is available, and if there are any concerns regarding general health, I'll have a discussion with the anesthetist as well. I'll inform the anesthetist that during the puncture, we might need to pause the respiration to attain a good puncture, and I'll always maintain a good communication within the team members. In the theater, after the WHO checklist, in a properly draped patient, I'll make sure that the antibiotics is given before the procedure. And for the supine PCNL, the procedure starts with positioning the patient in a slightly lateral position with the left, for this patient, the left side up, and the lower part will be in a modified Galdacao Valdivia posture, so that easy access can be obtained from lower down. The initial procedure starts from below, where a ureteric catheter is inserted through a cystoscope and a retrograde study is done to delineate the anatomy of the pelvic axial system. And the ureteric, we usually keep the ureteric catheter in position. This will be followed by the puncture into the pelvic axial system. Once the PCS is delineated, we usually use the Lingemann percutaneous tract dilator set. So that initial puncture, for this patient, it can be either supracostal or the lower pole puncture. So if it is a lower pole puncture, with the help of fluoroscopy and we usually use the triangulation method. So, and the initial puncture needle, which is 20 centimeter, 18 gauge as standard, and then puncture the lower pole. Once the urine efflux is there, once we confirm the initial puncture needle is in the calyx, desired calyx, a guide wire is put through the initial puncture needle. That is a hydrophilic guide wire that used initially, and make sure that that guide wire comes through the ureter and is kept into the bladder. And sometimes we take the guide wire all the way out through the meatus and keep it secure outside. This will be followed by serial dilatation. We start with the facial dilator 6 French, and in the set we have a 8-10 French sheet, which is a 8 French puncture sheet. And once it is done, we can slide over a 10 French outer sheet, so that a second guide wire can be inserted over that sheet as a safety. So we will keep the first guide wire as a safety guide wire. In the second guide wire, we usually use a super stiff Amplatz guide wire for the dilatation. Once we confirm that 2 guide wires are in place, we start with so by that time the track is dilated up to 10 French, so that we can insert a balloon nephrostomy balloon. We use the Nephromax balloon, and the couple of things we had to make sure is that the balloon, the initial gauge should be filled with the contrast, and we had to make sure that the Amplatz sheath is backloaded before the procedure. And the balloon is inserted through the working guide wire, the super stiff guide wire. Make sure that the radio opaque part of the balloon is beyond the desired calyx, and then inflate the balloon with the contrast. The balloon can be inflated up to 30 centimeter water, but usually we inflate up to 18 to 20 centimeter water. We'll make sure that the shouldering effect of the balloon is seen in the fluoroscopy. Once the shouldering effect is seen and the balloon is adequately distended, we will slide the Amplatz sheet over the balloon and keep the tip of the Amplatz sheet, and then the balloon is deflated. This is followed by an insertion of a nephroscope through the Amplatz sheet and visualization of the stone. Usually we use the ultrasound guided disintegration of the stone. So it is a combination of ultrasound and suction, and stone clearance is achieved. If needed, if in difficult situations, we use the flexible nephroscope to clear the stones from difficult access areas. After the procedure, after ensuring the complete stone clearance visually and radiologically, we'll keep a nephrostomy tube. And usually our protocol is to keep the nephrostomy tube overnight, draining overnight, and then reviewing the patient the next day, and usually we clamp the nephrostomy tube on the first post-operative day. And if the urine is clear, the patient not in pain, we usually remove the nephrostomy tube on the second post-operative day. So this will be my approach for a supine PCNL in the institute where I'm getting trained.
Okay, good. That's a quite nice detailed description. Now let us go into the small steps so that you are able to address the instruments and technology part of PCNL, and let us master it in the next 30 minutes. So coming to the position, you said Gladico modified Valdavia position. Yes, that is one of the commonly used supine PCNL position, and it is also known as flank free, which means you should be able to approach the flank in a very free manner, and two sandbags are used, one kept in the lower chest wall area, one kept just above the gluteal area, so that you have enough angle, especially when you're doing supine PCNL. Yes, supine PCNL, the lower pole puncture is relatively easy compared to the upper pole puncture. But when we are doing prone PCNL for this particular patient, upper pole puncture will give more better access, as I said, all throughout the PCS, up to PJ, good amount of lower calyces, and even the flexible nephroscope will clear it. You may end up clearing the whole Stargardt stone in single puncture in prone PCNL, especially with upper pole puncture. The other thing which you need to mention is the upper pole puncture will be a supracostal puncture. As you said, patient has to have a kind of a apnea in full expiration so that the diaphragm is elevated as much as possible. And you can still use ultrasound, nothing wrong in having an ultrasound in hand, but for these patients, image guided puncture will be more useful. The disadvantage with ultrasound guided puncture is it can result in a long track, and sometimes you need a good expertise in the ultrasound, which will have its own like a learning curve. Now, as we discussed, the main divisions of the equipments used for PCNL is the first group is access needles, and next is the tract dilators, and then we have the nephroscope and the various accessories like guide wires and forceps, which is also used similarly for ureteroscope, as we discussed in the last week's session. Now, coming to the access needles, what do you see here?
So I can see in picture 1, it is the access needle with the inner stylet. Picture 2 is showing the inner stylet on its own. Picture 3 is the two-part of the PCNL access needle. And sorry, picture 3, 4, 5 are parts of three-part needle. So it has got a inner stylet, inner sheath, and a outer sheath.
So what is yeah, good. What is the principle behind three-part needle? Why do you need that?
So a Chiba needle is an example of three-part needle. So the initial puncture and the inner sheath is around 21 gauge. So and the outer sheath is a bit shorter than the inner sheath and stylet. So the advantage is we can use multiple punctures, and the punctures are small because it's only 21 gauge needle, and it will decrease the amount of hematoma formation, decrease the possible injury to the kidney, and also there's a concept that it can decrease the formation of AV fistulas. So once the inner sheath is in place, then we can slide the outer sheath over the inner sheath. So that's the principle of three-part needle.
Yeah, so two-part needles are usually 18 gauge, while three-part needle is 21 gauge. As you said, we are using the thinnest possible needle to enter the calyces, and once we enter the pelvic calyces system, we can slide the outermost sheath of the three-part needle, which is a bigger one. And since we are in place, the chances of unnecessary punctures and even inadvertent injury to liver, spleen, or colon may not cause a major impact by 21 gauge needle compared to the 18 gauge needle. So what is this you're seeing in the picture?
So I can see three initial puncture needles, 18, 20, and 21 gauge. And I can see an echo marking in one of the needles, which will be good if you're using a ultrasound guided puncture. And I think the other picture is showing a trocar shaped the tip of the needle, and the lower picture shows a diamond tip needle, which is good in the sense that the diamond tip shape helps in, so it will not bend when we puncture, unlike the bevel shaped needles.
Yeah, the main advantage of the bevel shaped needle is because of the bevel. When you pass the guide wire will automatically come on the opening side of the bevel. So if you keep the bevel appropriately, you can easily guide the guide wire to enter the pelvic calyces system and pelvic junction into the ureter. While in case of the diamond tip needle, the guide wire will come absolutely straight, and if the calyceal infundibulum is not in straight front of you, you may struggle to pass through the infundibulum, and it's also difficult to negotiate into the pelvic calyceal system. But diamond calyceal tip needle is more stronger because it is uniform density everywhere, while beveled needle, because of the lack of support on one edge, it can bend, as you said. Okay, what are these things?
So these are the facial dilators used for the sequential serial dilatation of the puncture tract. So these are made up of polytetrafluoroethylene, and these are available from 6 French to 16 French as shown in the figure. So we will use this for the initial dilatation of the tract before the complete dilatation with either the balloon or amp plus or the alkane dilators.
So, say compared to the alkane dilator, what is the advantage or disadvantage of this?
The advantage of this is it has got a conical tip, so it can easily slide over the guide wire, and that will decrease the buckling or bending effect of this over the guide wire. And this is a bit more tougher, so that it will remain in position during the serial dilatation. The disadvantage is each time when we remove the facial dilators, the tamponade effect is lost, so it can cause a bit more bleeding when using the facial dilators initially.
Yes, that's most important disadvantage of these facial dilators, because every time you remove, if there is an inadvertent injury to a vessel, the vessel will bleed, and you should keep the next dilator ready and you should go in immediately. While in the alkanes dilator, your previous sheath will be always there, and you are concentrically dilating it over the previous sheath, so you always try to keep the tamponade continuously. Okay. What is this one?
So these are the amp plus dilator set. So it comes with initial facial dilators and then a cobra catheter for the initial dilatation and passing of guide wire, and the others are the amp plus dilators and amp plus sheath. So we start with the facial dilators first, and once the facial dilators, I think it is 6, 8, and 10, and once it is dilated up to 10, then we can insert the cobra catheter. So cobra catheter is a bit more stiffer, and it will easily slide over the working guide wire. And once the cobra catheter is in place, cobra catheter is 8 French, so that we can dilate serially, starting from, I think the first one is 12 French in amp plus dilators, and it will go sequentially in the division of 2, so 12, 14, 16, and we can dilate up to the desired French size. Usually we dilate up to 30 French for a standard PCNL, but there are amp plus sheets that are available from 24 to 30 French. So if you are using a 24 French amp plus sheet, we have to dilate only up to the 24 French amp plus dilator. So the amp plus dilator, the length is, I believe, 30 centimeter, and the length of the amp plus sheath is 16 centimeter. So that means that the amp plus sheath can easily slide over the amp plus dilator and can be kept in position. The disadvantage of amp plus dilators is each time a dilator goes in, and to put the next dilator, we have to remove the previous amp plus dilator. So it is like each time the tamponade effect will be lost, and it can cause bleeding. Usually, if we use amp plus sheath, we dilate up to 26 French, because our nephroscope is 26 French. So we'll dilate up to 26 or 28, and then keep the amp plus sheath over the amp plus dilator. And these are radiopaque, so can be easily visualized in the fluoroscopy.
Yeah. The most important thing is, if you see the markings, 18 French sheath and ample sheath is also 18 French. So
Okay.
20 French, and this is also 20 French. So indirectly what it means is, for the ample sheath we are measuring the inner circumference 20 French, and for these dilators we are measuring the outer circumference. So 20 French will fit with 20 French, 22 will fit with 22. How will you
Okay.
define mini PCNL?
The definition of mini PCNL is a track size between 14 to 20 French.
Okay.
Uh,
The
yeah.
reason why I asked is, so by using the ample sheet, you can even do mini PCNL because we have 18 French couple and 20 French couple. So if you dilate
Okay.
only up to 20 French, we can call your procedure as mini PCNL. If you got
All
a
right.
mini PCNL nephroscope, you can use that.
All
Anything
right.
dilatation above 20 French, 22 onwards up to 30 French, that will be like the normal standard PCNL. The patient which we are discussing, she will be an ideal candidate for normal standard PCNL because of the volume of the stones. So what are you seeing here?
So in this picture, I can see an M plus dilator uh, entering the infundibulum of a calyx. So this is the ideal puncture. It has to go through the center of the calyx so that it can avoid the puncturing the blood vessels around the calyx.
Okay, so you need to use few terms like blood vessels are commonly present in the fornices. So you should try to avoid puncturing the fornices, and calyx actually punctured in the center in the infundibulum. This
Mhm.
results in loss of a papillae. For example, this calyx papillae will be sitting here. So we will lose a papillae, but
Mhm.
anyway, the papillae will be lost even if you puncture the fornices and because of
Mhm.
dilatation. So we are losing a papillae completely of the calyx, but we are
Mhm.
preventing unnecessary blood bleeding. So the blood
Mhm.
vessels usually travel in the fornices on both sides. So this will be like
Okay.
the most avascular plane for the puncture.
All right.
What are you seeing here?
So this is the telescopic metal dilators, alkane metal dilators. So this is a method to dilate the access to PCNL track. So the principle is again there should be a stiff guide wire in position. And initially we insert the central rod. So central rod is 7 French in size with a knob at the tip, and the knob is 9 French. And the alkane dilators are serially numbered in multiples of 3 French. So the initial one is 9 French, and then 12, 15, and so on up to 24. So once we have to confirm under fluoroscopy that the tip of the knob is inside the calyx, and it is designed like the nine when we put the nine French uh, alkane dilator, it will go and stop at the knob of the knob is 9 French, and the serial uh, insertion of the further alkane dilators can be done smoothly. So it is designed like it will not overshoot the previous alkane dilator, and also we don't have to remove each time like in a M plus dilator. So each dilator will go on sequentially over the previous one, so that a smooth dilatation can be done, and all the time the tamponade can be maintained. At the end of the 24 French insertion, we had to we had to insert a M plus sheet over the 24 French, and then we can remove the whole assembly together so that only the M plus sheet with the safety guide wire is in place. Instead of the M plus sheet, we can also use a nephroscope sheet. At the end of the 24 French, we can insert the outer sheath of a nephroscope and then use a nephroscope sheet. The only disadvantage is that we cannot take off the nephroscope sheet like in a if there is an ample sheet is there, it is always easy to wash out the stone fragments by taking out the nephroscope. But in this case, the nephroscope sheet has to remain in position if we use the nephroscope sheet as the instead of amplus sheet.
Yeah. The main disadvantage and why we are not using this that frequently nowadays is, even if you miss one of the sheath, the whole set will go waste, and you can't jump and dilate. And the other main disadvantage is, you can see the distance from the knob tip to the actual sheath of dilatation. So if your calyx is smaller, especially in calyceal diverticulum, By the time you dilate 3 or 4 sheets and reach a 18 French, you may be already outside the PCS, and whatever your dilatation is only in the meat of the kidney. So
Oh.
that is the disadvantage, that you are not getting your dilatation, especially the maximum dilatation, up to the area of the desired calyx. So this is possible only if your calyx is nice and normal, especially for our patient. And these are all stainless steel, so they are reusable. If properly saved, this can be easily autoclaved and can be reusable multiple times. So economically, this may be a very nice option for a developing country. You said quite clearly about the knob and the role of the knob. That's very important to understand. The main other thing is you need to design exactly what amp plug sheet you're going to use above the 24 French. That comes with the experience, and you need to make sure that there is no big jump in the inner lumen, which can cause quite a difficulty in inserting the amp plug sheet. So what are you seeing here?
So this is the balloon catheter. The collapsed balloon is 7 French in diameter. And important thing we have to make sure is that the amplus sheet must be preloaded before the inflation of the balloon. Once the balloon is inflated, we cannot insert the amplus sheet. So that is one of the most important steps we have to remember while doing the balloon dilatation. It has got 2 ports. One is the inflation port, where we can attach the the pressure gauge, and then slowly inject the contrast into the balloon. And the other one is for the guide wire. So once the guide wire is in position, we will slide the balloon catheter using the channel for the guide wire. And once there is a radio opaque dot at the tip of the balloon catheter. So we have to make sure that the radio opaque dot is in the desired calyx. Once this position is confirmed fluoroscopically, we can start injecting the contrast. And usually we have to monitor the pressure in the balloon. Usually we go up to 18 centimeter of water for the inflation of the balloon. We can monitor fluoroscopically the inflation of the balloon, but the disadvantage of balloon is, one, this is only single use, and second thing, if it is like in a very tough tissue, like a repeat procedure, then it might be difficult to inflate the balloon in tough tissues.
Yes. So in this picture, you can see that the inner marking. So this marking should be within the pelvic calyxal system, and make sure your working guide wire is nicely inside the PUJ and into the ureter. The main disadvantage is if there is a tough facial tissue, or the patient with previous PCNL balloon may struggle, and sometimes if the balloon is not creating an appropriate resolution of the waist as you use, you can't proceed any further, and then you need to really start from the scratch and use the other facial dilatation methods. And amp plug sheath has to be preloaded. There are some articles published which says that the serial amp plug dilatation causes the pushing of the vessels laterally, and since it is done concentric manner, the chances of bleeding are less. But the, what can I say, the significance or the statistical significance is very minimal to choose between the balloon and the amp plug one. As you said, there is a channel for the guide wire and there is a channel for the inflation. The syringe used is known as a leave-in syringe, and the main important thing is the lever lock mechanism, which is what maintains the pressure in the balloon. It's a single-use balloon, but for the same patient, we have used few times the same balloon for creating the next puncture or the second nephrostomy tract. It works well. It won't be as brilliant in producing that cylindrical expansion like the first time, but anyway, it's a disposable one. You're not going to use it for the next patient. Okay. Now we have finished your patient, stag on stone, a good upper pole or lower pole puncture, as you said, and using a flexible nephroscope to clear the stones. Patient had a very nice intraoperative flexible nephroscopic inspection of all the calyces, and you're happy with the clearance of the stone. We are not going to discuss the energy sources for stone, which we have discussed in our ureteroscopy video quite in detail. Maybe we can do one more session later on the energy sources for stones in a different setup. Now, let us assume you got 2 centimeter left kidney lower pole stone for the same patient. What equipment you are seeing, and what is the difference between these equipments and the standard PCNL?
So in this picture, I can see the mini PCNL set. So it comes in 3 sizes. It is the 15, 18. So the outer sheet is there is a inner dilator that comes along with this one, and outer sheath. So it is the top one is called 1518, where the inner dilator is 15 French and the outer sheath is 18, and then 16.5, 19.5, and then 21, 24. So this comes like in a combined thing. So it always comes along with the inner dilator sheath. The principle is the same. Only thing, during the once the guide wire is in position, we have to initially insert the dilator along with the outer sheath, and once the dilator is in position, we can insert the outer sheath and then confirm the position in the desired calyx. And once it is confirmed, we can remove the inner dilator part. For the mini PCNL, the maximum size is described as 20 French. So we cannot we have to use a specific instruments for mini PCNL, which are smaller in size and which is very soft as well. So there's a chance that it might be damaged very easily. Most of the time during a PCNL, the energy source used is laser energy, and also there is a concept of whirlpool effect, where it is designed so that a fountain of the fluid can happen at the end of the sheath, so that a whirlpool effect can be created over the stone fragments. And once we withdraw the nephroscope, the stone fragments will come out easily. This nephroscope is also tailor-made for the mini PCNL. It contains 2 channels for the nephroscope. So one is for the irrigation and one is for the laser fiber to go in. And the lower part is shown as a tri-flange forceps, which is used to remove the fragments. And it is smaller in size and it is very soft as well for a mini PCNL set instrument.
Yeah. So based upon your laser settings, you may do even dusting or fragmenting. If you're doing dusting with whirlpool effect, you may not need the tri-flange forceps. You may finish with just using the whirlpool effect to clear the stones. The commonly used mini PCNL, especially the store set, is the 6.5 French. 6.5 is the inner circumference, while 19.5 is the outer circumference. For 15 French, it is 15 and 18. For the larger one, it is 21 and 24. As we discussed, the normal cutoff for mini PCNL is 20 French. So the 21/24 French sheath ideally is not ticking the box for mini PCNL. As you said, the central rod is used for dilatation, and the rods can be used both in the short length and the long length based upon the patient's obesity or BMI. And we also have the trocars, which is longer and shorter, which can be used based upon the skin to stone distance. Mini PCNL, as you said, laser may be a very ideal source, so that you don't have to depend on the very thin probes for ultrasound or pneumatic lithotripters, but they are available, and laser is the most commonly used. With the correct sheath size, especially with 16.5/19.5 sheath, the whirlpool effect is brilliant, and that will really result in very quick stone clearance rather than using the basket and forceps to going in and out again and again. So what are you seeing here?
So this is a setup for ultra mini PCNL. So I can see the outer needle, which is known as a all C needle. and there's an irrigation port and a telescope. This telescope is specially designed for the uh, this type of PCNL, and this is I think 10,000 pixel, so it has got good resolution compared to its size. So yeah, I think this is a setup for the. This is the smallest outer sheet available for PCNL.
Okay. This is not ultra mini PCNL. Can you change your terminology?
Oh, sorry. This is a micro PC. Oh,
Yeah.
sorry, I forgot that.
It is micro PCNL, or we can call it as micro perk. So
Micro perk, yeah.
this contains a 3-part all-seeing needle. That is the correct terminology to use, and it is 3-part, almost similar to the 3-part puncture needle what we discussed, and it has got micro optics, and optics are 0.9 millimeter, and it has got a very nice wide angle vision up to 120 degrees, and resolution is excellent up to 10,000 pixels. The main advantage is this needle, including the shaft, has an outer diameter of only 4.85 French, which is almost equal to the needle ureteroscopes what we discussed in the last class. And 4.85 French will transcribe to 1.6 millimeter, which is very similar to the diameter of a standard needle what we use, like 1.3 millimeter. So the needle is only 0.3 millimeter more than the standard needles, and it has got the flexible fiber optic telescopes, and the vision is brilliant. We got the irrigation port, and we have got the port for inserting the laser, and the advantage is you're puncturing under vision, so with experience you can claim that you can avoid bowel or any other tissues on the way, but the widespread use is very much less because of the non-availability of the microperk, and also the learning curve it requires. You can't remove the stones like ESWL. You can use the laser to just break the stones, dust the stones, or fragment the stones, and then it is a tubeless PCNL. There is no place for nephrostomy. You will be removing the microperk needle. The skin may be just cleaned and closed with some glues, and you can place a retrograde JJ stent if you are a bit concerned with the volume of the fragments, but patient has to drink more water and the stone should pass by itself. Not gained much popularity because of the learning curve and availability of the equipment in a widespread areas. What is this one?
Yeah, so this is the micro PCNL. So for this one, the sheet is 11-13 size. So this is tailor-made for micro. The telescope is tailor-made for micro PCNL. The principle is again a guide wire, and the dilatation is a single-step dilatation using the sheath. And once the desired calyx is reached, we can insert the telescope. It has got a working channel for the laser and irrigation channel. And yeah, so this is the ultra mini PCNL, which is 11-13 French size.
Yes, you're slightly using micro PCNL and ultra mini PCNL in a quite interchangeable manner. Possibly you're doing it without your consciousness, because you know the answer, but the words are coming slightly not in the same note as you are thinking, but we can understand that. The outer sheath, as you said, is 11/13 French, and this is relatively a very nice way of if a person really wants to miniaturize the mini PCNL also, I will say this may be the best way to stop. Micro PCNL will be too micro to handle if you are really interested in stone clearance. Again, in ultra mini PCNL, you have the port for the laser, and you have got a kind of a special tip so that the stones can be cleared during the surgery itself, and there is a small port for the irrigation, which is a separate port going all throughout the working channels. And the camera head, maybe you can use the same camera head because the head is the normal headpiece, so you don't have to have a dedicated camera head system. And overall, in PCNL, the main crux is how are you going to prepare the patient? How are you going to make sure that you get the proper CTKUB? As per the EAU guidelines, you need CT urogram only in some specific situations like patients with calyceal diverticulum or malrotated kidney or few other conditions. Normally in my practice, CT KUB is more than enough to plan, but some surgeons always do a CT urogram to get much more better patient preparation. Patient needs appropriate preoperative clinic nurse visit, stopping of anticoagulants, bridging therapy if there is any need due to like metallic heart valves, antibiotics as needed. If the patient had previous nephrostomy or previous JJ stenting, you can't stop with just preoperative antibiotics alone. You should continue the antibiotics at least for 2 to 3 days. And nowadays, the techniques have improved to the level of even doing day care PCNL. If the patient is done quite early in the day, we can discharge them in the evening, especially if it is a tubeless PCNL. And one night overnight stay is entirely acceptable. If you are not placing JJ stent and nephrostomy, it means patient is not having infected stone and you have cleared the stone completely. This is totally tubeless PCNL. If you just place only the JJ stent, maybe for nomenclature, we can say it is a tubeless PCNL. Usually the puncture site will heal brilliantly, and PCNL really made a lot of changes compared to the previous days of open pyelolithotomy or nephrolithotomy days. We are in the fag end of the discussion. Before completing, I'm going to show you a imaging picture to go through. It may not be an exam scenario, but it's nice to finish with a very nice challenging picture. Go through this for me.
So this is a axial view of the CT scan of the pelvic region. I can see I think this is a tube going into the kidney, but I can see the contrast in the. I think it's contrast in the bowel. So with this picture, I would think of inadvertent bowel injury during the PCNL, and the nephrostomy tract showing the contrast in the bowel.
Anything about kidney you want to comment?
This is a pelvic kidney, and this is really low in the pelvis.
Okay. Why a pelvic kidney can happen?
I'm not sure whether this is a horseshoe kidney because it is very low down there.
I agree, it's a quite challenging one. It's a pelvic kidney. That is a good spot, and you can see the pelvic bones there. The bowel is quite separate. There is no signs of any contrast leak into the bowel, so it's not an inadvertent puncture. The only thing is, if you look out, you can see the skin scar and healing. So this is a transplant kidney. So this is a transplant kidney where there is stone formation. You can see the stones here. These are all the stones, and maybe this could maybe a contrast, but these are all mainly the stones. This picture was taken from the so-called Bible of Urology, Campbell textbook. So most of the UK trainees may not have even seen the book. And this puncture is done by CT guided. So the whole picture is CT guided. So very rarely we do CT guided puncture because of the special situations where we need to avoid the bowel. So it's a transplant kidney, which you can identify by the skin and subcutaneous scar tissue. And the CT guided puncture is made. Once the puncture is kept, then the patient can be transferred to the OR and we can dilate and go ahead with the further stone clearance. And these patients definitely need stent. We got special small stents for the short ureter. Of course, you can even keep a nephrostomy overnight if needed. Any questions you have regarding the PCNL equipments before we finish?
No, I mean, this was a really deep discussion, and thanks for that. I'm happy with the discussion. Thank you.
Thank you. As I said, we always try to do a little bit more than what is normally required for especially the UK-based FRCS exams. I'm sure there is 9 out of 10 times you won't be asked much on micro PCNL or ultra mini PCNL. They may even don't touch much on the standard PCNL because they are all specialized procedures. But nothing wrong to know, and especially in technology, if the equipment comes, you should know a little bit more, especially the French values and other things. And as usual, this is the standard textbook from which the pictures were taken. Urology Instrumentation, a comprehensive guide. And our many thanks to the authors, Arvind Kanapule, Dr. Sujata, and Dr. Ravindra Submis. They have done a wonderful work, simple textbook, but gives a lot of inputs into the details of the equipments, which is very nicely done. And if there is no further questions, I'm quite happy to conclude this class. Thanks for the trainees joining all over the world for our YouTube class. Now in the picture, you will be seeing our previous UroTechnology class on ureteroscopy instruments on your left side. The center one is the button to subscribe, and the right side is our complete urology Viva exam preparation playlist link. Hereby we announce class dismiss.
Thank you so much, Mr.